So the debate was very active, but unfortunately there is no direct head-to-head comparison to date. So any conclusion about one being better will be only speculative. And guideline recommendations includes both as an probably A1 recommendation and individual patient factors, physician preference, specific country laws, available formulary, and finally the cost may probably decide. It's always beneficial when we have an active debate, and here two young cardiologists have done that. Even if there is no definite winner, but I have to add few things as a nephrologist. Especially these drugs, SGLT2 inhibitors, have been chosen, and you have got definite evidence in having a definite positive effect on heart failure with preserved ejection fraction. Many a time, patient comes to us, they are fluid overloaded, and still we think that there could be a possibility of heart failure in this. Patient can't lie down flat, especially night, and we gave a reference to the cardiologist. Cardiologist examines, does an echocardiogram, 67% ejection fraction, then they will say that your heart is absolutely fine. This is basically due to the CKD. And we never have got a definite drug for that at that point of time. But after the arrival of SGLT2 inhibitors, we do have definite, because obviously this patient has gotten heart failure with preserved ejection fraction. That is what we think. And unless the cardiologist says that you have got a cardiac problem, people will never accept that this is basically due to the cardiac failure that his symptoms are worsening. So I personally feel that such discussions like here actually that point has been brought down very well. Reduced ejection fraction and preserved ejection fraction. Reduced ejection fraction, everybody knows. The patient's ejection fraction is on the lower side. Obviously, the patient has got cardiac failure. And I probably feel that it's more difficult to treat a preserved ejection fraction than a reduced ejection fraction.
We have a 1 hour session on preserved ejection fraction coming up, don't worry. I mean, the debate was excellent, and both of you have proved your points. But as our nephrologist and Murali sir was saying, unless we compare it molecule-wise, we will not have any data. I will just conclude by quoting Albert Einstein before I give it to Murali sir. In theory and practice are very important, but in practice, they don't matter. I think we have enough evidence for both SGLT2 as a class is absolutely useful for us. When in one of the sessions, when McMurray is one of the big man in SGLT2, was asked, what will you choose? He said, impossible to say. But personally, I will choose a diabetic heart failure EMPA and non-diabetic heart failure DAPA. I mean, these are personal observations. But please use an SGLT2 in every heart failure, be it reduced, be it preserved. Last word. Do you want to take the audience? We can take it now.
Poll.
Audience poll. How many of you will? Okay.
See, Jayaraj has told that there is no head-to-head comparison. That will never come. That is number one. Secondly, the trial design has shown some benefits for the EMPA, but trials and reals are totally different. As far as a patient in the Asian population or especially the Indian population, you will get the real world trial only after the drug has been in the market, even though it was in the market. Now it has been really promoted and it is coming into the limelight. About 2 or 3 years of experience with this drug in the field will probably answer some of these questions, provided there is somebody prepared to undertake a post-marketing surveillance on this matter and see what is the head-to-head relevance of this particular thing.
Even the two.
Will you give it equals to somebody
The guidelines do not say that. Of course, EMPA has come down to 20. So if it is less than 20, a patient already on empagliflozin and then he is progressively deteriorating, if it goes down below, I will continue.
For the pleiotropic benefits of
For the
EMPA
pleiotropic
in heart failure, even though.
I may not start in a patient who is on dialysis.
So based on
But
whatever
obviously these patients do have that particular.
we will stop. I think we have crossed our time.
Yeah, but SGLT2 benefits on the hyperglycemic side will continue even with a lowered EGFR. So that will not be affected.
So based on the observation, how many of you want to switch from DAPA to EMPA? Kaiboka. So no more questions. Thank you very much. You did a wonderful job.